So very importantly, welcome to this new Ultrasound Journal podcast. Adrian and Francesco are here again. And most interestingly, for our viewers, I'm no longer in my grey jumper. I've got a new white jumper that Francesco kindly put. But we're joined by a very special guest. Gerda, do you want to introduce yourself?
Yeah. Hi, everyone. Thanks for having me here. First of all, it's a pleasure. And my name is Giada Pucciolini, and I'm a neurointensivist consultant in the hospital of Pisa. And I am as well a PhD student in Pisa as well for the University of Pisa. Yeah, so please go
Wonderful.
ahead.
Wonderful, wonderful. And we've already recorded lots of material that we're not going to play, but the manuscript that we are discussing today, and at some time today, the authors may or may not join us, is the impact of demographics and positioning on the imaging features of the optic nerve sheath and ophthalmic vessels. Okay. That's why we got Giada here, because she's a neurointensivist. And she's also done a stint at the Brain Physics Lab in Cambridge. So she's definitely an expert in this field. And I am a dabbler or enthusiast. Francesco, as the
Yeah,
editor in chief of the Ultrasound Journal, what do you think of this manuscript then?
I think that it's interesting because optical nerve shelf diameter is growing, is gaining a growing and growing interest in the scientific and clinical community, and I'm quite fascinated by the optic nerve shelf diameter, but really I think it's interesting, it's smart, it's useful, but on the other side, I'm not really convinced on its feasibility and reproducibility. And most of all, because as a clinician, when uh, I start measuring the optic nerve shelf diameter, I got that it was not that easy to acquire. First point, and the second point, I think I have no issue concerning the physiology and the importance of the measurement, but I guess that we have a huge technical gap because we are talking about a tenth of millimeter. So this is my point.
Okay. So,
Yeah.
just to make sure that everyone knows what we're talking about, Gerda, do you want to just summarize very quickly what the optic nerve sheath diameter, what is it supposed to do?
Yeah. So the optic nerve sheath diameter is essentially the measurement with the linear probe just put to the eye of the patient. That this measurement measures the sheath that envelop the nerve, and the optic nerve is enveloped by the meningeal layers. So essentially, if you have an intracranial pressure rise, the sheath is supposed to enlarge, and that enlargement is particular because it has a proper shape. It is elliptical in the way it enlarges, and the proper measurement needs to be taken around 3 millimeters behind the bulb. So essentially, you need to put the probe on the eye of the patient. And it's suggested to do it with a protection for the eye and a reduction of the mechanical index of the probe to preserve the retinal vessels and neurons of the patient. And then you take the measurement with the probe generally in a transversal orientation. Yeah, and there are actually some debatements about where to take the measurement, because with the echographic anatomy, you see a central part that is generally dark and is representing the nerve. Then you have a hyperechoic, let's say, part that represents the subarachnoid space, and then a thin hypoechoic structure that envelop everything that is the dura mater. And the suggestions of the last consensus conference said, just as a convention, to measure the outside of the hyperechoic fascia. And
Okay.
that's the physiology.
Okay, we're going to put a picture together with the show notes just to illustrate it better so that colleagues will do it. And I think optic nerve sheath diameter as a non-neurointensivist has always been there. The idea is a very, very nice one. It says measure non-invasively, reducing your mechanical index, and it gives you an idea of intracranial pressure. So especially useful when you may not have more invasive measures of intracranial pressure. So you don't have a bolt, etc., etc. Then you have something like this that is non-invasive. You can continue doing it on a regular basis to monitor. That's where utility, I think, is sold. One of the problems, I think, at least in my head, is what Francesco's mentioned, which is around reproducibility. So you are talking about sub-millimeter measurements or even millimeter measurements where you can decide that's okay versus that's not okay. And so this has parallels to what's it? Diaphragmatic thickening, because it's all very, very small measurements. And the minute you make a mistake, then you can swing patients one way or the other. And in reading this manuscript, what colleagues in Portugal have done is essentially taken a group of healthy volunteers and they've changed their position from a sitting to supine position. And they found that, perhaps unsurprisingly, the positional change does impact those measurements. Okay. And in particular, unsurprisingly, again, if you sit up, those measurements, the size of the optic nerve sheath itself reduces, gravity essentially. Okay, so that's not surprising. I suppose the bit that I'm less familiar with, and I find it very interesting, and again, we'll put the show notes on the show notes, which is the use of the ophthalmic or retinal vessels, and in trying to get a bit more information about what's happening in the brain. As a brief summary again, most of us who practice point of care ultrasound are familiar with the idea of transcranial Dopplers of especially the middle cerebral artery to give you an idea what brain perfusion is like. Okay, and you can have that parallel to other arterial vessels as well. Okay, but in this case, we use the ophthalmic artery and the profiles would suggest high resistance, low resistance, and therefore high pressures, normal pressures, so on and so forth. I'm going to be honest, it's not something I use regularly at all. Francesco, Giada, any thoughts on this? Francesco, what do you reckon? Are you convinced that ophthalmic vessel Dopplers has something to add?
So I think it's once again, if the optic nerve sheath diameter is not easy, I guess that the assessment of the vessels, artery and veins, are tricky and are an advanced application because it requires a deep knowledge of the ultrasound device settings, gain, and PRF and filters. So it's definitely an advanced application. So this is my first point. Concerning that point, Jada, go ahead.
Yeah, it is not easy at all. I've been training some students for this technique, And it's very easy to sample the vessels in an incorrect way. So, and often you cut out the diastolic part of the flow. And so you're like tempted to say that the ICP is high, but maybe you're just sampling it not correctly, especially if you have the eye that is not aligned and the patient is not looking straight ahead, because you do have a patient that maybe is unconscious, so not collaborative, and with the eye that is rotated either with external or towards the internal parts of the face. So yeah, it is not easy at all. But and even it requires the knowledge. I mean, you need to distinguish from the vessels that are into the sheath versus vessels that are into the orbit but outside of the sheath, because they are different circulations. So, for example, the ophthalmic artery is outside of the sheath, so it doesn't, it is not affected by the ICP, but it is affected, for example, by eventually a stroke. It might be affected. So you need to sample only the central retinal vessels for the ICP assessment, let's say.
No, I agree with this one. I'm looking at my side screen because I'm trying to revise the anatomy of the blood flow to the eyeball, which involves the long posterior ciliary artery, the short posterior ciliary artery. Obviously, for people like Francesco will already know this. But to me, I'm looking at the picture going, I think I knew that when I was in medical school. I cannot say I know it now. So lots of technical. It's a very technical thing. So I suppose and given the what the paper highlighted again is positioning, so on and so forth. So, I mean, as Francesco, as you said, brain ultrasound is almost become is sort of receiving the Italian word a renaissance in interest again, not just within neurocritical care, but also in outside neurocritical care. So in the general intensive care, maybe in liver intensive care, those sort of things. Having read all these papers, how do we put it all together? Where does optic nerve sheath diameter and or ophthalmic vessel Dopplers, where would they fit in? So we'll Giada, for you first. So how as a neurointensivist, where does these two techniques fit into your day-to-day practice?
Yeah, I think that these are useful techniques, first of all, to say yes or no, like, do we have an elevated ICP? It is a qualitative investigation, and this answer might be important, for example, in an emergency department when you have an unconscious patient, maybe a traumatized patient, or maybe after a cardiac arrest. So you want to monitor patient that has not received an ICP monitoring probe. And even in neurointensive care, because sometimes you have patients that underwent surgery, for example, but don't receive an ICP probe because they don't need it at the moment, but they may deteriorate, or they may require a new surgery, or they just don't awake after the sedation holiday. So you might need to answer the question of the ICP, and you might perform a comprehensive focus examination, including the optic nerve sheath. That might be a first line measurement, but you can combine it with the VESA's measurement or even the MCA evaluation, flow evaluation, if you're able to. And there are other advanced techniques that I use in neurointensive care, like the evaluation of the midline shifts or the hydrocephalus, so the measurement of the third ventricle or the lateral ventricle as well. So yeah, I think that might be like a part of a more complete evaluation, or a measure that in an emergent situation might be a scan, just to say a first line measure to say it might have an increased ICP, so let me check if I need to do other investigations.
Francesco, thoughts on a
Yes,
general intensive care unit?
yes, I have a very mixed feelings, and more I try to get in the topic, more my feelings are very confused. Because, first of all, concerning general ICU, I guess that the assessment of what is going on in your bed is even more important than in neurocritical care patients. And why? The reason is because in the general ICU, I don't never, usually never, basically a bolt inserted inside, and also the facilities of assess brain anatomy by computer tomography. It depends on the context. For example, a patient with acute respiratory failure submitted to prone positioning. Yes, it's possible to move the patient to the radiology department, but probably it is not that easy, or for sure they got submitted to a much lesser extent to the assessment by computer tomography. And this is the reason why we need to assess what is going on in their brain. But up to now, it's only an emergency field of application. And I think we are not so keen to assess septic patients or shock patients, generally speaking, in the context of the assessment of the hemodynamic assessment of their cerebral hemodynamics. I want to provide you an example that arises from my clinical practice. I guess that the assessment of medial cerebral artery, or including optic nerve short diameter, or if you prefer, the early detection of an ongoing cerebral edema in patients with an RDS, in order to set mechanical ventilation and to try to choose the positive end expiratory pressure, is something that if it can be done by ultrasonography, it's the perfect field of application, because I don't think it's reliable to insert a bolt in a patient with only an RDS, but it's not only an RDS, because RDS doesn't only affect the lung, but also the brain and much more, obviously. So another context is septic encephalopathy. Why?
I'm glad you picked that example. I've got a bugbear on that, but I'll let you continue first.
What is going on in a patient submitted to septic shock who eventually recovered, but he doesn't get awake? Why? So I think that septic encephalopathy is something new. It's a new, I don't want to say a new field of application, not a new illness, but it's something that we start to get mind to this entity. And I think that brain ultrasonography would represent the perfect tool for these patients.
I think I like that. So as a non-neuro intensivist, one of the problems I face, and I or rather what I think about is there a better way to look after the brain in our general intensive care patients? So for example, the septic patients, and there must be something beyond sedation hold, CT scan, sedation hold, CT scan. Okay, this in deciding parameters, perfusion, that sort of thing. And this is where I think my interest in MCA TCD comes into play, because it gives me an idea. It's better than just relying on a CT scan. And this is why I'm also interested in the optic nerve sheath diameter. Could it allow me to look after my non-neuro patients a bit better? I have to put my hand up. I'm not an expert in MCA TCDs. I do scan them. My success rate, I blame the patients, obviously, not mine, my thick skull or something like that, in terms of whether I can get the views or not. And optic nerve sheath is definitely more accessible, at least in my hands, compared to MCA-TCDs. Now, accessible doesn't mean more accurate. That's the first thing to say, because as both of you alluded to, there are technical aspects to getting the TCD and optic nerve sheath diameter that needs to be overcome. And some would argue that you're better off not having the number than measuring the number incorrectly and therefore acting upon an incorrect number.
Yeah.
So that's where I sit when it comes to optic nerve sheath diameter and MCA-TCD. I definitely like your point, Gerda, about a more holistic approach. Now, in the same way as when we look at the heart as an example, we have the parasternal long, parasternal short, the different views to have you get an idea in terms of the heart is doing this, the circulation is doing this. Optic nerve sheath plus minus Dopplers of the retinal vessel plus minus MCA-TCD to me is a more multi-parametric view of what's happening in the brain. I think that's how I'm going to utilize it, if that makes sense. Thoughts on
Yeah.
that?
Yeah, totally. I think that it might reduce the error as well. So you can combine the measurements, and if you get discordant like clues for the ICP present or not, you might not be confident of what you did measure. But if you get all the clues in the same direction, that can trigger further actions. So yeah, it definitely makes sense. And regarding the septic encephalopathy or general ICU patients, I think that there is much biochemical stuff in there.
Yeah.
Like probably the ICP only is not the reason why these patients deteriorate or fail to awake. Um, and so I think that TCD, it certainly might be useful, like TCD on or optic nerve sheath diameter and echography in general, might be used to have a first line view of the brain of the patient, but it probably come out negative. Like
Okay.
the
Yeah.
patient
No,
won't probably
fair
have,
point.
yeah.
Okay, so summing up, we think that optic nerve sheath diameter may have a role, but there are lots of technical aspects associated with getting the measurements, and then
Mhm.
when it comes to the retinal vein, retinal artery, vessels, TC Dopplers, again there are technical issues around it, which brings me to the issue of training to make sure that people who are doing this are doing this properly. Gerda, you've already mentioned that you're starting to collect some data in your practice, and I'll ask Francesco after, with his expertise as a trainer, how are we going to how are you doing it? How are you training people to do this properly? Any tips and tricks?
Yeah. First of all, there are some protocols that have been published regarding the accuracy of the measurement and how to take the measurement fairly. So, first of all, you need to be sure that you're cutting the nerve parallel to its axis.
Mm-hmm.
So, generally, you need to have in your image like the anterior chamber of the eye, the optic disc, and then the central retinal vessels, and that ensure that you're correctly aligned with the nerve.
Mhm.
And then it's not easy, like it's much difficult when you have the eye that is not aligned, and probably there's not so much consensus on how and where to take the measurement in that case. But yeah, and I've been training some students, and even there is some nurse that is trying to take these measurements in our unit. And I think that it's easier if you're already ultrasound user,
Yep.
advanced user,
Yep.
because you have clear in mind what it is a correct image and how you can cut not properly the image, and what are the needed movements to adjust that image. But if you're already an ultrasound users, I think that it's quite fast to learn on how to take the measurement. If you're not an ultrasound users, I don't really know, but probably you need to look at many exams.
So,
Um,
so Francesco's already mentioned a point right at the start that he thinks this is an advanced skill as opposed to a basic skill. Now, the ultrasound journal, Francesco as the editor, have always been very supportive of educational centric manuscripts. And what's interesting is that you've gone for this is not a beginner level skill. There's been recent guidelines and publication consensus statement that suggests that this is a core level or a more beginner level skill as opposed to MCA of the posterior circulation, as an example. Francesco, as an editor, as a researcher, as a trainer, thoughts, where does this sit then? How do we train people to do this? Should we be training people to do this?
So I think that the assessment of the optic nerve sheath diameter, or generally speaking, the cerebral vessels, are basic in the meaning that they represent a very useful basic building block. But from the technical point of view, I'm not so sure they are not that easy to be assessed. It's something that comes to my mind like the lung ultrasonography. Lung ultrasonography is a technique easy or not? I don't know. To visualize some B lines is that easy, actually. To interpret B ultrasonography is much more tricky. The visualization of the optic nerve sheath diameter, the optic nerve artifacts, are easy to visualize. I think are very easy to visualize. To align the beam, the ultrasound beam, in order to acquire the proper measurement is difficult, and people does not make mind on the issue of reproducibility. Okay, so this is the first point, to visualize the papilla, to measure the diameter in between 3 millimeters from the retina. The outer border measurements is not easy. This is the first point. And the other consideration is that for some reason, that probably is represented that we learned this application by neurologists and neuroanesthesiologists, is that we start studying the brain by assessing the Doppler. So we adopted a top-down approach to the assessment of the brain, starting with the top difficult assessment of blood flows, and we forgot up to now the assessment of B ultrasonography. I would like, generally speaking, as a general approach to the brain, to start assessing B mode ultrasound of the brain, looking for midline shift or whatever, no? Including
I
huge
agree.
autocoma,
I agree
something
with
like
that. Yeah.
that. Then the assessment of measurements, okay, bidimensional measurement, optic nerve diameter, and after that, the visualization of vessels, artery first, and eventually veins, because otherwise it's not possible. It's not possible because the in the patient where the brain ultrasonography is can be mostly useful are those patients where the measurements are very, very important. Are very, very important. So I think that most of the time I consider, I think that the assessment of brain ultrasonography is very important because when we put to hemodynamic management, talking about fluids, talking about vasoconstriction, we go through the kidney, the abdomen, the gut, the liver, the heart, including congestion of the lung, but nobody cares about congestion of the brains.
I would argue that's because the ultrasound techniques are more accessible. It's easier to scan the kidneys, the heart, the circulation. The brain, as you said, is sort of is a it's a skull. There's a skull sort of in the way. Yes, there are certain windows, but I completely agree with you. I think Aguirre gave a really good point that there are technique there you're trying to learn. Okay, there is a learning curve in all of this. Why do you scan the kidneys? Because it's there. Okay, because it's there. It's just so much easier to scan, and the brain is just a bit more difficult. I'm not saying it's more important. I know my neurosurgeons are going to hate me for saying that. They're not saying it's not important, but it is something that we can access to. And I think, like I said, I think this is one of the reasons why brain ultrasound is becoming it's undergoing a bit of a renaissance. That people have started to realize that we scan all these different things. Why should it be that we only do it in the other situation of a neurocritical care setting? We have all these other patients. I'm sure it's the same in Italy and Pisa, Giada, where a traumatic brain injury doesn't necessarily make it onto a neuro intensive care unit. There are people who've had too much to drink, fallen on their head, they ended up in a general ICU, not a neuro ICU.
Yeah.
So to me, there are those issues that we can do this as well. So that's where I think that's why I'm starting to think more and more that anyone who looks after these patients should have skill some skill when it comes to assessing the brain using ultrasound. And I really like the way Gerda's put it, which is, it's a holistic approach. You use all these different parameters there, and it's not just the MCA TCD. The challenge will be is can we train people? Can we get colleagues engaged to the point that when I look at the measure, when someone says to me, the optic nerve sheath diameter is X or the MCA TCD index, it is this. Is this a reliable measure? Can I believe these things? Gerda, you're going to say something.
Yeah. I think that it should be like a basic skill if someone is caring of these patients, like as you said, a traumatized patient that goes into a general ICU, or
Mhm.
maybe you don't have the neuro ICU because you're in a peripheral hospital.
Mhm.
So you need to give the basic care, let's say, before other investigations that might trigger you to transfer the patient. But you need at least to do the optic nerve sheaths and MCA. I think these are two basic skills that might enter into a general approach to the brain. And probably we might say that if you see it enlarged, yeah, you're sure that there is or there has been an intracranial hypertension. If you see it not enlarged and you're not confident with the measure, that is not an answer, right?
I go with that. It's more concordance between all the different parameters and
Yeah.
the clinical setting. I think we all agree, treat the patient first before you don't treat the image necessarily per se. We've gone on for over half an hour now, so our time is up. So
I would
what I'm
like
definitely going to do, go on, Francesco.
I would like, sorry, because I forgot a very important point that I want to arise with you and with all our readers, that is the assessment of brain hemodynamics, mainly the medial cerebral artery, and also optic nerve sheath diameter in pregnant woman looking for eclampsia, because the combination of these two measurements and other hemodynamic behavior is very useful into the characterization and by phenotyping this type of young woman. So this is a very important point. Yes, once again, I think it's basic to learn how not to apply. The second comment that I would like to share with you, because this represents a very gray zone, okay? But in my opinion, we have three main field of application that are represented by diagnostic, assessment, prognostic role, and in order to guide the treatment. So I'm very confused about its diagnostic role and accuracy. Very, very confused. I would like to share your thoughts concerning this point. I would like to know, I don't want to say I'm pretty convinced because it's a presumption, but I would like to know its role in prognosis, because if the congestion or if the brain represents an issue, and probably it is, the more the optic nerve sheath diameter is enlarged, the more the prognosis is worse. Probably is not a statement, it's a research gap only. And the third point is represented to the assessment of mean cerebral artery, basically, not because it's the most important, because of the only that I know, okay, and we have data on the assessment of a resuscitation, looking also for the brain and not only the heart. So these are the 3 points that I think should be discussed. Not solved by us this night, but discussed as a research gap.
Essentially, Francesco, what you've issued is a call to colleagues out there to help you become less confused. So, colleagues out there, if you want to help Professor Francesco Corradi become less confused, drop him an email, drop him a paper, That's more important. Drop him a paper for consideration at the Ultrasound Journal. So, as a wrap up, thank you very much, Giada. Thank you very much, Francesco, as always. We will put some show notes, hints and tips and tricks onto the podcast episode to help people learn this skill as well. So thank you very much, everyone. Have a good evening.
Thanks everyone for listening.